Hello everyone, very good evening to all of you.
Hi, ma'am. Very good evening.
How are you?
Fine, ma'am. Going well.
I'm sharing video, my PPT with all of you, and then we'll start talking. Hello, hi everyone. Now, okay, good to go. You can see the slides.
Yes,
You
ma'am.
Yes, ma'am. See.
Okay, great.
Yes, ma'am.
So, first we will start with a little bit of introduction. I know that the timing is very important, and we don't want to waste it. It's already 8:04 as per India. This meeting is being transcribed for AI companion. Okay, stop sharing and let's discuss with each other. I'm sorry, ignore this. There was a kind of festival, so that's why that Mehndi thing is there. A very good evening to all of you. As usual, this learning is very important for all of us as a physio, and I hope you all are comfortable with the language English, and I only know these three languages: English, Hindi, Gujarati, a little bit of Punjabi, but I don't know the Tamil and that language. So I'm so sorry if you don't understand, and if you have any difficulty, you can always ask me in English. Okay, English is always good for all of us. Yes. Uh, when we talk about that learning program, so really want to make you very comfortable. Be my friend from the starting, and don't see that I'm your guide or something. We'll just keep learning with each other. I'm also learning, and you might tell me something if I miss. So keep adding from your side also. Keep exploring more during this time period whenever we are going to go through this important subject which we have missed in our curriculum so far: pelvic floor rehabilitation and the understanding about this muscle, its function, dysfunctions, assessment, and the treatment. If you know that something I am missing somewhere, or if you have any suggestion which might be important for the patient care, so please keep writing or keep raising your hands, and we can always discuss about that during these 8 to 9 days or 10 days of time when we are going to go through this. If you see any patient in your clinic, so I really want you to do a little bit of assessment towards that area also. Now, core assessment. So pelvic floor is a part of the core. So start assessing the core. So I'll give you that external assessment. So don't feel that pelvic floor is something where we have to remove the cloth and only then we can go for assessment. No, external assessment is also possible. So you can keep doing that little bit with your patient, starting from tomorrow itself, whatever understanding you're getting from this webinar, and keep discussing the patient. I have shared you one link of my pelvic care international group where we are discussing always the patient. So you can keep an eye on that group also, because from that group itself you can have a lot of understanding and learning about this patient and case studies. Very helpful group. And you can also write your about your patient, whatever finding is in the same group, or you can call me, or you can send me a message also, so I can also help you what next we can do. And that is going to give you a little bit of practice, of asking questions, taking history. It will be very helpful. So yeah, without taking me as your senior or someone who is expert, count me as your friend, and please keep pen and copy with you. So keep writing all your doubts on one page if you have, and also keep writing whatever information you found is valuable, because sometimes whenever I am doing this kind of training sessions, I sometimes, the experiences also comes, patient experiences, things are not into books, might be something is missing in my PPT, I might just say, and it might be it has a value which you might miss. So it is very important that you keep note something which is important. I will keep sharing the video recording with you after the session, but not the same session. I will not share you the video of the same session which is happening. My past webinar, same topic, but past webinars link. Might be you get some revision also through that webinars, and you get a little bit extra also from that webinar, because people keep asking me questions. So every question can give us a little bit of more understanding and learning. So by hoping that at the end of our completion of our sessions, I don't know how much time it is going to take. It might take 8 days, 10 days, or might be 12 days also, depending upon how much questions you guys are asking. The subject is very, very, very deep actually. And when I say that, I'll just tell you the 100 hours is also less. So it's a kind of continuous process. And so I will try to give my level best during this particular time period. But I am expecting that after completing this, you will be someone who can easily assess or understand any case related to the pelvic health, related to the pelvic floor. This session is specifically for female pelvic floor rehabilitation. We have a male different. There are some muscles which is different, some conditions which is different in male case also. So I might not be able to cover that part in detail, but I will keep giving you a little bit of understanding wherever it will be important. And I hope that we will enjoy this learning program, and it will always stay with you, and it will always help you in our community. This particular service is not there. Not everyone is serving this area. So the good news is that we can be the kind of, there's no competition actually, no such competition. So we can be that expert in our area, and that can also help in a little bit of your career growth and new patient flow to your clinic. So far we are somewhere dealing with the musculoskeletal, neuro, cardio, that rehabilitation, but pelvic floor, like helping the community with urine incontinence, helping the community managing some prolapse issues, or managing constipation, or managing that piles, hemorrhoids, back health, which is related to that core actually, whenever we are saying. That is going to be a kind of, adding something extra in their life, which not every physios are doing. Little bit more assessment, little bit extra depth, treatment and care. This way, their rehab will be very easy, and it will be kind of permanent. They will not keep coming with the same issue, because you will understand how to deal with it. So by keeping that in our mind, let's, with the good and great hope, let's start our learning about pelvic floor. So if I tell you that pelvic floor muscle, so you might have heard some of my videos, someone else, people are also saying, and nowadays it is into era also. So many of us, we are practicing into pelvic floor, we are educator into pelvic floor, we are doing this training, and yeah, it is very important because something it is missing. You might be thinking it might be very tough, but I will try to give you the learning in a little bit easy way, so that can stick with you forever. Okay, I have a PPT. I will also share books with you after completion of this webinar series, so you can always compare the learning with whatever you have written on that notes. You can always go and just check that with the books also. So definitely it will help you, and books will also help you in sharpen your skills more later on, but I will try to make it easy. So that should not be into the mind that it's very tough, and that shyness, because this muscle, this area is very private. So we are not very comfortable asking the question directly to the patient about the pelvic health. But I will try to give you some solution of that also, that it is compulsory. Every patient which is coming in your clinic, doesn't matter what issue they are suffering from. It might be the abdominal weakness, it can be the COPD cases, it can be there is a thoracic pain, there can be back pain, there can be foot arch, there might be TMJ. Everywhere it is related to the pelvic floor. You can understand in our body, the pelvic floor is a central part. We have upper half and we have a lower half, and pelvic floor somewhere is in the middle. So upper side and lower side, everything is going to affect this muscle. And if this muscle is not strong enough, it is very tight also, it has a weakness, it can definitely affect your upper body and your upper side as well as your downside. Okay, so definitely more better care you are going to add after learning pelvic floor in your life. So with this hope, let's start. Yes, PPT is there, but easy way. So if you see that we have our like cavities in our body, so you can see that this is the thoracic cavity. After that, we have abdominal cavity. So thoracic cavity is separated with this abdominal cavity through this abdominal diaphragm. So we have this abdominal diaphragm, and then we like the thoracic cavity, abdominal diaphragm, and then we are having the abdominal cavity. After this abdominal cavity, we have some pelvic cavities also present there. Into pelvic cavity, pelvic organs are lying. And after that, the floor of that pelvic cavity is made up with a muscle, and that muscle we are calling it as a pelvic diaphragm. So we have two, you can say that we have two important part. One is upper part, one is lower part. So diaphragm is up, abdominal, diaphragm is down, pelvic floor. So very important. And the way I'm making my hands, you can say we have a little bit of, upward ascending way. So this ascending is very, very important. So this is our dome shape diaphragm, abdominal diaphragm, and same way we have ascending, means upward, we have pelvic floor, pelvic diaphragm. So these are the two important part of your core, abdominal and pelvic diaphragm. Very, very important. So abdominal diaphragm is the floor of your thoracic cavity, and pelvic floor is the floor of your pelvic cavity. The way we have thoracic organs are present, same way we are having our pelvic organs present into this pelvic cavity. Now when we say the pelvic cavity, so I'm talking about this important area, and when I'm just holding it, so this is a bone, and we all understand this bone. We have a pubic symphysis anteriorly. You all can palpate your pubic symphysis by touching anteriorly. So we have this pubic symphysis right and left, and they are joining the pubic bone, and they are joining with this kind of connective tissue. We call it as a pubic symphysis. So right and left pubic bone, and then we have this ilium going on, and then we are having sacrum at the back. So ilium, pubic, ischium is also there downward, which is, you can say this is the ischial tuberosity. You can just move right to left and you can feel this sit bone. So we are talking about this sit bone. So we have this sit bone. Posteriorly, we are having this coccyx. Then we have this sacrum, and this is to ilium. So when this ilium is joined with the sacrum, so this is sacroiliac joint. Yes, we all know about this important fact. Anteriorly, again, there's a connection. Now downward, if I just rotate it like this, so downward we have this area. So all of this area is covered by these muscles, which we are calling them as a floor of the pelvis. So these are the pelvic floor muscle you can see into this model. Okay, so this cavity is completely covered and protected by this floor. So in this way, you can see that there's a bowl shape. It is making a bowl shape. And into this bowl, our pelvic organs are present from anterior to posterior. So why it is very, very important now you can understand, because this muscle is the very, very important part is that it is somewhere stabilizing the whole bone. So anterior to posterior, lateral to medial, this muscle is the muscle has a good tone. So this stability of the pelvic bone will be good. So if these muscles are somewhere, you can understand if they are very tight, too much of tension is there into the muscle. So what will happen to all these openings? Like to this, you can see this ischial tuberosity of this side, coccyx, or you can see pubic symphysis. So what will happen to all these areas if the muscles are tight? They will be kind of tension. So the bone will come closer together to each other. The moment the bones will start coming closer to each other, so they were having a neutral. But now assume that bone are the muscle is tight. So what will happen to the bone? They will be kind of pulled together. The more the bone will get pulled together, you can understand there will be increased space anteriorly around the pubic area. So patient can complain about pubic symphysis pain. The same thing can happen during pregnancy. Whenever this female is relaxing hormone is improving that inlet, just to accommodate the baby. So this inlet is increasing. So you can understand the pelvic downward will be kind of congested at the particular time period. So that can be a reason of pubic pain in a female, pubic symphysis pain. And same way, if these bones are coming closer, you can carefully see what will happen to SI. Can you see there's a little bit of space? So definitely SI joint pain can also come into picture. So the bone is directly going to give you the strength of this muscle. Tension into this muscle is going to directly give you back pain issue. That's why this muscle, and anteriorly you can see over here our core muscles are also coming and they are inserting. If pubic is going for separation, that is going to weaken up that abdominal muscles, anterior wall, and same way you can also say it is going to affect the posterior wall also. So the downward part, if that is tight, so this ascending, so that can give you anterior pain as around the pubic symphysis or posterior pain around the sacrum. And if these muscles are tight, they can definitely, because muscles are going to attach with the coccyx, the tailbone. If these muscles are tight, so you can understand they will pull the coccyx anteriorly, and patient will be always complaining about the sacral pain. So sacral pain, SI joint pain, pubic symphysis pain, weakness of abdominal muscles, tension into the back muscles. So yeah, all is somewhere affected by the tension into these muscle. And the muscle is, it will affect. Same way, if this muscle will be saggy, loose, weak, so you can understand it will not be able to pull the ischial tuberosity in a stability, that position. So this ischial tuberosity will go away from each other. You can understand because muscles are holding them in a neutral position. The moment these muscles are weak and saggy, they will not be able to pull the ischial tuberosities closer to each other, and they will not be able to maintain the stability. In this way, what will happen? Mild, if you can say, mildly, look, again, there will be pain at the back, at SI joint pain, back pain. So again, it's going to cause back pain issues in a patient if muscles are weak. You might have seen a lot of your patients, they are coming for back pain issue, back health issue, but their back pain is not going. You are treating them here and there by doing everything, but still their back pain is not going. Now, why? There might be you haven't addressed that base of that might be tight or weak. So this assessment is very important if your patient is suffering from back health issue. Okay, so you can understand how important this floor is for back. Same way, if this floor is tight or weak, it can definitely going to affect your central muscle of abdominal, that is your rectus abdominis muscle. And that if you have a linea alba, so you can see that if these muscles will be, this pubic symphysis will go for separation because muscles are tight down there. So that can definitely going to give you diastasis recti below the navel like this over here. So diastasis recti can be present in your patient. And back pain, definitely the sacral pain, and that issue will be present in a patient. So yes, linea alba. And if these muscles are, you can understand that if these muscles are loose and saggy, so they are going to again strain your obliques. So again, obliques will be tensed, tight, and they will keep pulling your rectus abdominis. Again, the diastasis recti at the umbilical level. So yeah, so that is what is the core with the pelvic floor. Okay, so very important. Uh, we should learn about that, understand this muscle, and try to help our patient with this core. What we are saying is abdominal. If tension is there, or the weakness is there, or back tension is there, or weakness is there, or the pelvic floor. So that is the one correlation. And the second very important correlation is abdominal correlation with the thoracic cavity. You can understand that we are all, with a very important part of our life is a breathing. Breathing is and we don't know, but we keep doing this breathing normally. We don't focus on the breathing. So there's a kind of passive movement somewhere going on. When you are sleeping, also the breathing is going on. Have you ever thought how this breathing is, what this breathing is doing? Yes, it is like we are providing the oxygen to the organs. We need, the cells needs that, but or they are creating some kind of maintaining the pressure into the cavities. The moment you are inhaling the air inside, your thoracic cavity is expanding, isn't it? You are feeling air in your lungs, and that is going to give you chest expansion. And during this, when the chest is going to go for expansion, the diaphragm of your abdomen, this thoracic cavity is going to descend. You are feeling, assume a balloon, you are feeling a balloon, you are feeling air inside that balloon. So the more you will insert that air, you put the air inside, the balloon will go for expansion, anterior, posterior, 360-degree, and even downward also. The dome shape diaphragm will descend downward, and it means the thoracic cage is expanding, and the pressure is there. And this pressure is going to even, you can understand, push the diaphragm downward. And due to this downward push of this diaphragm, where the pressure will increase, what will happen to the abdominal pressure? So because when you are descending, you're pushing something down, so this descending of the diaphragm is going to increase the pressure in the thoracic cavity also. So increase of the pressure in thoracic and abdominal, abdominal also. Downward, so it means more air there. So means abdominal is also going to go for expansion, and pressure is going to increase into that area. So if this diaphragm is moving down, pressure is high into the abdominal cavity. So in abdominal area, all the muscles anteriorly, obliquely, posteriorly, you can understand, assume another balloon there. So that balloon will be pushed down. So due to this pushing downward, it will expand anteriorly, posteriorly, laterally, as well as downward. So this pressure, abdominal pressure, increased intra-abdominal pressure is going to even put load on your abdominal cavity as well as your back and the pelvic area. So into the pelvic area, we have organs. Now, which organs are present? Assume that bladder is there, uterus is there if she's a female, rectum is there. So this downward pressure is going to increase the pressure over the organs. If I'm an organ, pressure is increased, I will be descending down. I will be under the load. So I will affect. So same way, I am doing my functioning. I'm bladder, I'm collecting the urine. I'm a rectum, I'm collecting the feces. I might be, that reproductive area of a female. So every organ is present, and every organ has a canal. So as a bladder, I'm collecting the urine, but I'm storing it. I'm not keep passing it, throwing outside. I am storing it. And male or female, the people, they have a control. They will only going to urinate as per their, their wish. If they see there's a urinal is there, they will go for urination. If the urge will be there. If there's no urge, they might hold the urine. So I have to keep expanding as a bladder. So I have another passage attached with me, and the name of this passage is urethra. So this urethra is going to pass through this pelvic floor, because you can understand this muscle is present, and the outside, if I'll just place this organ here anteriorly, so this is a bladder, and bladder urethra is passing out through the through this pelvic floor. So pelvic floor is working like a support around the urethra, support around this bladder. So bladder is resting on the inner muscles, deeper muscles of the pelvic floor, and its canal urethra is passing through the whole pelvic floor outside. So you can understand that this muscle should have a strength, good tone to support the organ against that pressure which is coming in, which is building in inside that abdomen. So this is very important. So if the muscles are strong enough, they will keep this ascending pressure when this descending pressure is going on from the abdomen. But if the muscles will not be strong, so what will happen to the these canals? So that this pelvic floor is weak. For example, they are weak, so there will be more descending pressure, and during this increased intra-abdominal pressure, there might be more descending of the organs downward. You might have heard about pelvic organ prolapse. So why the organs are falling down? What is the reason behind that? The reason is because muscle is not strong enough to keep increasing the ascending tone. So tone is not good. It is descending tone. And due to this descending tone, gravity, downward, we are always playing around against the gravity. This muscle is kind of transversely placed muscle. And gravity is always pulling it down in our all, walking, running, jumping, sneezing, coughing, doing any job, whenever we are standing. And you can understand the gravity is always going to pull it down. So you can see that this muscle should have a good strength tone to work against the gravity and to support the internal pressure which is coming during normally also throughout the day. And very important that this pressure should be maintained during those activities which is increasing intra-abdominal pressure, like sneezing, coughing, jumping, pushing. Whenever your intra-abdominal pressure is increasing, as a physiotherapist, like no one can be better person rather than you to understand how much in a day our intra-abdominal pressure is always increased. So we are loading the patients, we are giving them exercise, we are giving them stretching exercises, we are loading their heavy limbs on, we are giving them stretchings. So our intra-abdominal pressure is somewhere on a higher side. So this is what I have seen in my practice, that most of the physiotherapists, they have weakness into the pelvic floor due to this always descending, increased internal pressure and descending pressure over the pelvic region, and they are not aware about the pelvic floor muscle action. So you can understand that yes, this breathing, and normally also, and as well as when it is forceful breathing, that can even have more increase of this pressure inside. So yes, it is important. When you are doing forceful breathing or like assume that you're holding the breath like this. So which conditions we are holding the breath during defecation? When you are constipated, any patient is constipated, they will keep having this kind of that kind of pressure. This descending pressure can weaken your pelvic floor. So that's why the constipation is a culprit for that weak pelvic floor also. So you can understand the increase intra-abdominal pressure somewhere. Whenever the person is keep doing that in his or her life, it can be the athletics, the sports people, when they are lifting the heavy loads, you can understand their pelvic floor will be worsen pelvic floor. So if any person who is having high, tight six packs, so very tight core, so in that case the pelvic, there are high chances that pelvic floor can be either weak or either tight. So assessment of pelvic floor is very important whenever we are having high training, high intensity interval training. It can be high weight lifting, whatever. So athletic people, that activities, sports people, when they are doing a lot of jumping, running, high chances that their pelvic floor, their pressure will be always increased abdominal pressure, and that can definitely affect the pelvic floor. So it is very, very important that we understand these muscles in a deeper way. And the second is, yes, as I told you, that how it is related to the back health, how it is related to the breathing. Now, whenever we are breathing, our diaphragm is moving down, increasing the pressure into the abdominal cavity, increasing the pressure over the pelvic organs, and somewhere it is putting descending pressure over the pelvic floor. So they are working like a piston on the same direction, pelvic, the abdominal diaphragm and the pelvic diaphragm. During inhalation, they will descend down. During exhalation, when you are exhaling, exhale out, so it will be ascending diaphragm. So pressure will be now go up because you are taking the air out. So your diaphragm will be relaxed. It will go for contraction like this. Same way, the downward pressure which was increased will also relax, and that will take a pressure out from that abdominal area as well as from the pelvic organs, and the pelvic floor muscles will be also relaxed and will be kind of come in a neutral position, ascending. So they both will ascend during the exhale and the both will descend during the inhalation. So now I want all of you to practice this important, uh, uh, kind of correlation of both of them. So if you are ready, just simply exhale. First leg breathing. Try to do exhale for 4 to 5 seconds. And when you're exhaling, can you focus around your pelvic floor? Is it ascending? Can you feel some contraction down there? Do it. You need to do. This is your homework. And when you will inhale, you will feel your pelvic floor is descending down. So this is very important correlation. And now, if someone's breathing is not perfect, it is not good, so you can definitely rule out how this breathing will affect the pelvic floor. In this sort of breathing in my patient, what sort of pelvic floor, there are high chances what kind of pelvic floor my patient will be having. So it is very, very important that just simply by looking at the patient breathing pattern, we can assess the status of the pelvic floor. And how to treat the pelvic floor? By correcting the breathing pattern, isn't it? So it is very important for all of your patients, not only specifically to pelvic floor. All the patients, when they are coming, do check their breathing pattern, and according to that, you can just guide them. So very, very important. Now, as I'm telling you that these are the importance of the pelvic floor, and same way, the organs health is seriously depending upon the health of the pelvic floor. Every organ, if I say that this is a bladder, so bladder is present into the pelvic cavity. I know that bladder cannot stay there if the floor is not there. It will fall down, isn't it? So we need this floor. But if this floor is weak, so definitely the bladder will start descending down because the floor is descending down. So if I'm holding something on my hand, and if my hand, if I increase the surface area, so definitely whatever I'm holding, it will descend down because I don't have the strength to hold the organ in a right position. So the good strength, or you can understand, look, this is how it is descending. Okay, so this descent, so organ support is the first priority of this muscle. If the muscle is not strong, organ will displace down. If this muscle is very tight, so you can understand this was my urethra and the bladder, and I as a muscle is very tight. So what I'll do, I'll always keep increasing the ascending pressure over the organs. And due to this ascending pressure, I will not let this part of the organs to relax, and they need to relax during their functioning, during the filling of the bladder, during that evacuation, urination, they need relaxation. But if I'm tight, I will always keep creating congestion around that area, and I will make their function difficult. The patient might have difficulty in kind of collecting a good amount of urine because there's always congestion going on the surface. I'm not letting the bladder expand as a pelvic floor muscles because I have a tension down there. I might not let that urination happens because I'm tight. I will not let the urethra to expand. So the tension into the muscles will give voiding difficulty. So patient will not be able to pass urine, hesitancy in passing urine. So whenever patient is telling you that my urination time is I'm taking too much time into urination. I don't urinate completely. I'm just doing dribbling all the time. I'm spending a lot of time into the washroom. So it means that we need to definitely check these muscle status. They might be tight and they might be creating congestion around that area, congestion around the urethra, around the bladder, not letting them to do their functioning. So this is what is we are calling a very important functioning of bladder health. And this bladder health is now directly related with the pelvic floor. You can see that. And not only this kind of congestion they will create when the muscles are tight. If these muscles are loose, so what they will do, they will not be able to give support to the bladder, and bladder prolapse, organ will start descending down. Urethral prolapse, urethra can start coming outside. Prolapse, we are calling it as a descending of the organs, because muscles are not strong enough to provide a better stability support around that urethra, support around the bladder. That's why they are descending downward. Okay, prolapse can happen. Or if these muscles are weak, they might not be able to provide a better contraction around the urethra. And if they will fail to provide contraction around the urethra throughout the day, our bladder is keep collecting the urine. If internal sphincter means urethra is also weak, if the tone of urethra is also weak, you can understand, and my muscles are also weak. So what will happen with this patient? Leakage, dribbling of urine continuously throughout the day, because muscles are not creating a sphincteric action, complete closing action. They fail to create that action. So it means leakage can be another issue. Okay, or whenever increased intra-abdominal pressure will come, there might be sneezing, coughing, laughing, jumping, more pressure over the pelvic organ from the abdominal cavity, put pressure over the bladder, and urine will move downward, and that can come outside during sneezing, coughing. This is what we are calling as a stress urine incontinence. During that stressful situation, stress when the internal pressure is increasing, the stress is the pelvic floor muscles are not, they fail to take that stress. It means they are so weak. That's why patient is leaking. Okay, so you can understand that, yeah, bladder health is directly somewhere depending upon the pelvic health. If pelvic floor muscles are not good enough, they are over tight or they are over loose, they will definitely give a patient or person bladder health issue. Not only the female, even the male, because muscles are present there. And male muscle, like in case of males, when we say there are some muscles of pelvic floor directly attached around the prostrate, that is the gland, and the urethra, directly they are attached with that. So you can understand, whenever the patient, the male is going for prostate surgery, they are removing the prostate. So you can understand those muscles which was attached with the prostate, they will be very either removed or either be very weak. So that's why 80%, the studies are showing 80% of the people of male after having prostatectomy, they have a leakage problem. 80% is a big issue. I know these surgeries are going on in a later age, 70, 80, 90, but 70, 80, 90, that generation, that people, they are suffering from leakage issue. So we are giving them home care, we are giving them home health, physiotherapy. So why we are ignoring this important part of their life? Why they have to wear diaper? We need to give this, you can assess them, charge them, take extra sessions. You can add extra revenue to your kind of income also. And you can give them expert care of that particular area which is affecting them. So why not? Why to miss it? Okay, so it is very important for male as well. Same way, if I'll say that we have another organ which is present which is very important and basic organ for our function, is the rectum. So large intestine is a part of large colon, and this is the last part which is keep collecting the stool, and it has an anal canal, and you can see that I'm placing it here. And if I'm placing it, anal canal is passing through this pelvic floor and coming outside. You have anus out. Every day we are passing stool out from this canal. So you can understand the status of these muscles around the area. We are calling them anal muscles, pelvic floor muscles, external anal sphincteric muscle. So they are very important. The first, yes, very important because they're supporting the rectum. So they have to work as a good supporter. So the tone is important, just to maintain the angles, maintain the upward pull. So stool can just keep descend, should not keep descending down. And not only they are supporting the organ, they are also supporting the veins which is present into the anal area. So in our whole vein, arteries, vein, we all understand their functioning. Now the veins around the anus, they are ending around the anus also, anal region. And after that, we have these arteries, and after that they have to take the blood back towards the heart. So we need venous return towards heart from that area, whatever veins are around present around this part. Now these muscles are strong enough, they will keep creating a contraction, pressure, maintaining the angle, and we call it as the anorectal angle, external anastomotic pressure. If that pressure will be kind of upward pressure will be there, so you can understand if this is a vein and they have to pull the blood back towards the heart, I need this venous kind of return. So this muscle, this my other hand is a muscle, if these muscles will be weak, they will not create a compression. And in this way, what will happen to this blood? This blood will keep, and we have a gravity downward. Gravity will keep pulling the veins down all the time. Now, if these muscles are strong enough, so what they will do? They will compress it. The more they will compress, so better venous return will be there towards the heart. And we will not have this kind of dilation of the veins. This dilation of the vein is nothing rather than this hemorrhoid and piles. So what is hemorrhoid and piles? Kind of protrusion of this vein. Why these veins are protruding down? The reason can be weak pelvic floor, isn't it? And when they are weak, they fail to create a compression, so they fail to create a venous congestion, a venous return. So this is very, very important that we have to understand. And you can do your research, you can search in any book or anywhere. 80% of people, they have hemorrhoids. So kind of big issue. And what is the treatment? Removing the hemorrhoid or doing that kind of some little bit of surgeries and using this and that. But the best thing that we should prevent the hemorrhoid is that keep creating the squeezing, strengthening, keep increasing the strengthening strength of your muscles. They should have that tone to keep creating compression over this vein, because when they will have strong strength and tone, they will definitely apply upward pressure, and due to this upward pressure, venous congestion, venous return will be facilitated. So yes, we can prevent hemorrhoid by giving the good pelvic floor contractions around the anal region. And if they have already happened, depending upon which grade, we can definitely help them by strengthening the pelvic floor. Not only the strengthening of pelvic floor, even tension into the pelvic floor can also give you hemorrhoid. So hemorrhoid, we will understand that in more detail in upcoming sessions, but you can understand that how even in hemorrhoid and piles, our patient needs our care, and pelvic floor is important. Okay, and how they, not only the piles or hemorrhoid also are, I don't want all the time, like, stool should keep the leaking of the stool. Oh, it might be the worst situation in anyone's life. So the stool, so this organ is collecting the stool. This is the organ. What the organ will do? It will expand to collect, and then it will contract to do the defecation, so that they can contract and relax. And that is under this autonomic nervous system control. We cannot control that internal system. Okay, so yeah, that is we can understand. But if I don't want to pass stool, I'm outside somewhere and there's no urinal, or there's a situation I cannot go to toilet, I'm stuck somewhere in the traffic or in a bus or in a car or somewhere, I can't defecate. So at that time, what this muscle should do? They should create a strong contraction. If the muscles will be strong enough, they will have a tone, then only they will contract. They will contract where? Around the anus. The more contractions means they will push back, thus they will increase the pressure internally into the anal region, and due to this increased pressure, the stool will be moved back towards the rectum. The descending pressure will not be there, and urge can be suppressed. Okay, so it is very important functioning of the pelvic floor. You can delay your defecation if you want in those kind of situations, those kind of circumstances when you have to do that. So, but who can do strong pelvic floor? Assume that you are somewhere outside and suddenly urge came and your muscles are weak. So what will happen in this case? Your urge will be more and might be not able to control, and sometimes your patient might feel this kind of leakage, and this is what we are calling it as a fecal incontinence, not able to maintain the continence of feces, who the organ itself as well as the pelvic floor muscles. So they are important for maintaining the defecation and this continence around that area. And if you want to, the other side, if you want to see that if I want to pass my stool and I'm sitting on a commode, so what I want at that particular stage, our internal system is completely relaxed. Bladder, this rectum is relaxed, that is ready to create a contraction. But if these muscles which is present around that area, this anal muscles, if these muscles are tight, so I might feel difficulty in passing my stool. So that can give you defecation issues or incomplete emptying, or it can be painful defecation. Okay, so that can be also I'm not saying I'm not using the word constipation here. Constipation can be due to different regions. There can be so many reasons of constipation, but one reason of not passing your stool and having difficulty in passing the stool or defecation can be tight pelvic floor. Okay, so if the tight pelvic floor will be there and if you can't pass the stool, so what will happen in your system? You always there will be incomplete kind of voiding, incomplete emptying of the stool due to the tension. Patient might spend more time into the washroom. And another thing is not only that more time into the washroom, because there's not complete voiding of that, so there will be always some kind of gas-like scenario going on, always kind of indigestion they will feel, gas-like sensations. Or you can see that what is going on, congestion going on around the anorectal area, or we can say, yeah, it is anorectal congestion. And if that congestion is there, too much of pressure, so you can also understand how it will affect the back health. This rectum is placed the same way, the same line, like, you can see from here, following the sacrum angle. So this is our sacral angle and then this is the angle. So same way here. So if you have a congestion going on around that area, you can definitely feel a lot of tension on your sacrum or all the structures. I'm not saying only the muscles, the facial sheath, the nerves, that arteries, that lymphatic system, everything will be under the congestion around the posterior part. And your back pain will be definitely can be one of the symptom of your patient. Okay, and blotting inside, back not able to defecate, I'm having a back pain. So isn't it making a sense that next time when your patient is coming for back health, should we ask about their constipation, their bowel movement? The answer is yes, of course. We need to ask them, what is the status of your bowel movement? Are you defecating every day? Or are you constipated? You can use a simple word, but they can understand. Are you constipated? If they are constipated and they are saying, yes, I'm passing this stool two times a week, or every alternate day, or it is very hard for me to pass this stool. So it is very important to give them that understanding that why the constipation is there. Try to find out, go towards the constipation. Might be the constipation is one of the reason of their back pain. Might be the pelvic floor can be the one of reason of their back pain. So pelvic congestion. So in this way, what is that? What is that body actually? I always believe movement. So we need mobility everywhere. We need mobility in my rectum. I want mobility in my anus. I want mobility in my pelvic floor muscle, and I want mobility in my whole body. If mobility will be restricted, so definitely congestion is going to affect me somewhere here and there. So very, very important role it is playing into bowel health. So bowel health is, yes, pelvic floor, bowel health. So bladder health maintenance, bowel health maintenance, back health maintenance, core health maintenance, abdominal health maintenance, breathing maintenance, everything is somewhere affecting our, somewhere related to the pelvic floor. Now, same way, if we are a female, so in a female body, another organ is present which is situated inside the body, and that is uterus. And two ovaries are main reproductive organs, ovaries, two right and left, and two fallopian tubes attached with this uterus. And uterus having this cervix, and this cervix is open into the vagina. And every month, when after puberty, when our periods, our menarche starts, so every month endometrial wall is going to form here, and if female is not getting pregnant, so this endometrial wall is going to shed out, okay, out through the vaginal canal, and they will come out, and we can collect this blood outside with our pad, sanitary pad. And you can understand that this canal is, so this is the organ uterus, which is inside, ovaries inside, vaginal canal is a passage, through this the blood comes out, and this passage and this whole organ is placed middle into the pelvic cavity in the central area. Okay, so they are like this. And when I'm placing it, you can understand this, what vaginal canal is passing through the pelvic floor. Now, anterior to this vagina, anteriorly this organ was present first, okay, bladder. And now posterior to that, vagina will go like this, and this organ will, uterus will like this, kind of anti-verted, anti-flexion, you can see. And this canal will pass, and then posteriorly, the rectum will be placed. Okay, so this is all three pelvic organs present into the pelvic cavity, anterior to posterior. Anteriorly bladder with urethra coming out, okay. Then uterus, vagina, which is a canal coming out. Then rectum has a canal, anus coming out. So these three organs anterior to posterior. More anterior, bladder. Any one of you, if you haven't urinated, you palpate suprapubically. Yes, you have a pubic symphysis. Just touch there right now. You touch there and press like this downward. When you press, you will feel urinal sensation. So in this case, you can understand your bladder is expanded and came into the abdomen. So this bladder is highly mobile organ. It can, whenever you are passing urine, it is empty. The bladder will be like a pouch, a squeezed pouch, and it will go into the pelvic cavity. When the filling will start, it will keep expanding and it will come into the abdominal cavity. And when it is full, if you press, you can even literally feel the sensation of your urinal sensation, that I have this sensation. Okay, so this is the most anterior organ, both in male and female. Okay, and rectum is most posterior organ, which I already explained. So in midline, in the middle area, anterior to posterior, we have uterus. Reproductive organ is also present. And all these organs are into the pelvic cavity, supported by the pelvic floor muscle, and we are calling them as abdominal organs. And if the muscles will be tight, it will create a congestion, tension, tightness, ascending pressure over the organs. And it can be anterior ascending pressure, means difficulty in passing urine. It can be ascending pressure over the vagina. Upward might be difficulty in penetrating inside the vagina, finger penetration, gynecological examination, insertion of the tempore, insertion of the cup will be difficult for the female. Ascending pressure is there, so not relaxed completely. Or it can be that posteriorly the anal region is under the congestion. Any one of these things are congested or tight and they are not able to relax completely, we can tell that can come under this bigger broad perspective. We can say pelvic congestion syndrome. So pelvic congestion means pelvic organs are not able to relax completely. Somewhere there is a difficulty in their movement. That it can be bladder health affected, bowel health affected, or reproductive health affected. So you can understand, if I'm saying this word reproductive health affected, so you can understand we are somewhere talking about the reproduction of a female. So if you can see that I'm saying that this is the vagina, and I know that every month we have this eggs are, our ovaries are doing their functioning, and the eggs are coming into the fallopian tube. And if the female wants to get pregnant, so she needs sperms. For sperm, the penetration of penile structure is very important. The more closer the penis will go towards the cervix, the more better the sperm will go travel towards the uterus. So we really want the full complete entry of the penile structure inside the vagina. And at this particular time period, whenever female is also, they both are they're doing their intercourse and they are doing their functioning, you can understand the uterus is also contracting downward. Even the penis is also there, which is ejaculating the sperm. So it means this particular part is coming down. So this ova, the egg, is facilitating, ready for that kind of fertility. And same way, sperms are also ready to travel towards that area. So we need mobility during that intercourse time period. And if the mobility will not be there of this organ, so there might be congestion somewhere there. And you can also understand, okay, I'm not saying only the mobility of this uterus, even that vagina. Assume that vagina is crossing the pelvic floor, okay, like this. And in this way, if these muscles around the vagina, if they are tight, so intercourse might not be possible. Penetration will not be possible. If penetration will not possible, so ejaculation of the sperm will not be possible inside the vagina or towards the uterus. So female cannot get pregnant. Believe me, in 2017, I started practice in 2016. Actually, I was still exploring that era, the subject in 2014-15. But 2016, I started experimenting by that, asking the questions, histories, taking the history from the patient. 2017, I got my first patient. She was married since 9 years. Her age was 28 years, and she never had, in 9 years of marriage life, they never had intercourse. And the whole family was, they don't, the whole, because if me and my partner, if we are not sexually active, we will not reveal it to the family, isn't it? Sometimes we try to hide it. And the family keep asking them that they want they want baby. And they were taking her for the fertility. She was taking this, they were forcing her for IVF consultation and this and that. And this female came to me in 2017. And when I asked her, she told me that she told so many other doctors also that she never had intercourse with the partner because sperm, that penis can't go. She has always pain in that area. So you can understand, 9 years of marriage, never had sexual intercourse. And the second thing is, you can understand that she can't get pregnant also. It is somewhere affecting the motherhood, not only the womanhood, even the motherhood. She can't become fertile. She is fertile, but she can't get this fertility due to this tight pelvic floor. So just relaxing the pelvic floor, you can add a lot of things from your side in improving, facilitating the movement inside, the movement of whatever is there. It can be the urinal movement, it can be the sperm movement, it can be the uterine movement, it can be that rectal movement. Movement is very, very important. And this pelvic congestion can always affect the movement or create the restriction over the organ, and definitely affect the health of the system, whatever is under more affected. So if anterior muscles are more tight, bowel health will be affected. Posterior muscles are more tight, back health or that bladder health, posterior muscles are tight, bowel health will be affected. Anterior are tight, bladder health will be affected. And the muscles around the perineum, that around the vagina, around that penile structure, if they are tight, around the base of the penis, if the scrotum, if those muscles are tight, there might be difficulty with the reproductive system. So the understanding of these muscles are, now you can understand the importance of that. And so many of people, they are just living like that, because even we are not, when we are still, yeah, we are, the awareness is there, but still the taboo is very high. Speaking about freely, discussing freely about that area. I'm not saying that you come and go to tomorrow and start asking your patient, oh, you have a urine leakage or you have a constipation. very systematically by understanding your community, your culture, the way, the language, like modification, simplify, and making it more comfortable for your patient. Very subtle, in a very subtle way, it is very important to understand the pelvic health. If that health is not good, the system will not good. Okay, so this is highly, highly, highly important. So we will definitely go on that. But before going on, so you can understand now how bladder health, sexual health, I haven't used that word sexual, but reproductive health, bladder health, sexual, reproductive health, as and this reproductive health, when I'm saying about the penetration, this penetration is important for male. If assume there's a couple and they are into love with each other, and but still they can't do penetration inside. So I know the female is into pain, but as a male partner, he will not force the female to go for penetration. So it is going to somewhere affect their relationship also. So it will affect the couples, it will affect the relationships, it will affect their mental status. So definitely psychologically also it is going to affect. And when she will not get pregnant, it is going to affect her socially also. If she will leak, any female who is leaking the urine, she can't control urine, she has a urine, it is affecting her mentally, psychologically, and socially. Okay, and same way the rectal issues are also there. Yes, they are loud, they can tell you I have back pain, back pain, back pain, and they might come to different people, they might come to us also. So only focusing on that one aspect is not complete rehab, because this health is that you can understand, you can see in this image. So this is sacrum, and these muscles are directly attached with this lower part of the sacrum. So they're providing the stability to the sacrum. If the sacrum pain is there, back health is there, so these muscles, we are always giving them piriformis stretching. Piriformis is tight. So this part is, yeah, definitely covered by the piriformis. But just down to the piriformis, which muscle is there? Coccygeal muscle. So this coccygeal muscle is also very important, and this coccygeal muscle is a part of the pelvic floor. So we should not count it as the sexual only. A bladder health, bowel health, back health, everything on a kind of holistic approach we need to see. It will affect anterior, downward, everywhere, the whole alignment. If the muscle, and now another thing, not only, so you can say the whole broad base is covered by this muscle as a center. So if I'll tell you the simple assessment, which all of you can do, I don't know you. I have never taken your history. I don't know your age. I don't know your history, your status, whatever. But a simple assessment, will you do for me? Just simple, do your TMJ test. Okay. Today you palpate your TMJ with touch and by pressure also. All of you do that. This is the second homework. First, you have to feel the breathing, ascending, descending, and how it is when you are breathing in and breathe out forcefully, how it is affecting your pelvic floor. First, do that. And the second is, please palpate your TMJ or do your 3-finger test with your mouth. If, according to that, if you cannot insert your 3-finger like this inside your mouth, there might be tightness into your TMJ. And if your TMJ is tight, there are high chances that you will have a tension in your pelvic floor. Okay, so tight pelvic floor might be, you're not having urine leakage, urine issues or urination, passing urination, don't have any pain. Having sex, you might have or might don't have pain, or during passing. But if you have pain here, you will definitely, there are high chances that there will be pain in your pelvic floor. If you have more laxity, your 4-finger can go inside your mouth and your TMJ is lax, so that can definitely going to show you weakness in your pelvic floor. There are so many studies which has been published. You can look on like scientific research gate, but this PubMed, you will find out how TMJ is related to the pelvic floor. So I'm not saying that remove your clothes and lie down on the couch and then I will assess your pelvic floor. That is the only way. No, You can simply check their TMJ, and if some issues are there, some pain is there, yeah, they might be pain into the pelvic floor. And even reducing, relaxing the TMJ can relieve the pain from your pelvic floor. Even strengthening the TMJ can strengthen your pelvic floor. So because of the, now what is the reason why they are connecting? You have to give me this answer tomorrow. Send me that answers in the group so we all can understand what is the relation. If you found any studies or something like that, keep sending that relationship of TMJ and the pelvic floor. So that's another very important parameter to check the status of the pelvic floor indirectly without removing the cloth. Okay, so yeah, that is the second homework for all of you. Not only this upper connection I'm saying, even the lower connection. Try to understand any patient. If, okay, assume that someone's this ischial tuberosity are away from each other, means they are not uh, pulled, muscles are, they don't have tone, muscles cannot pull them together. So weak and lax muscle, if muscles will be weak and lax, so what will happen to the ischial tuberosity? They will come closer or they will go away from each other? The answer will be, yeah, they will go away from each other, isn't it? Because muscles fail to pull them towards each other. So stability is hampered, unstable. Unstable means they will go away from each other. When they will go away from each other, so now try to understand if your descending perineum, descending pelvic floor muscle, descending pelvic floor muscle will fail to pull ischial tuberosity together. So what will happen to ischial tuberosity? They will go away from each other. If they will go away from each other, all of you understand the biomechanics. If ischial tuberosity will be out, means hip pelvic open, okay, pelvic is open downward because it is outwards. So you can understand the moment I'll make my downward part outward, you can say how this upper ilium is moving anteriorly. So they are going to create a tension into the side obliques, those muscles, and they will go like this. So how they will impact your knee, your adductors? What will happen to that? If you will there will be more gapping of your ischial tuberosity, they will go away from each other. And what will happen to your knee? So with the moment you go like this, your knee will come closer. Okay, that bow, no, not bow, that what do we say, the other word, well, gum. Okay, so welcome. The knees will come together, so you can, because you have the ischial tuberosity are away from each other. When the knee will come together, so what will happen to your feet? So what will happen to that inner part of your feet, foot arch? Will there will be high chances of getting foot arch, or sorry, flat foot or high foot arch. So in this way, when the knees are closed, then that what, flat feet, isn't it?
Yes,
Yes,
that's flat feet.
yeah. So you can understand that on any person, if he or she start like standing in front of you, just if it is not congenital, that it was not present since the birth, that flat feet. If you can just check their flat feet, and by looking at that feet, and it is flat, so you can, the knee, it is away. So what can be status of each outward? So what can be that status of pelvic floor downward? Then you can ask them that, okay, you have this flat foot, or you have a pay, and then you will found some muscles status of that Janu verum also, okay, those muscle tension. And same way directly when you go up, if you'll ask them, you will found the lateral muscles of the abdomen will be tight, obliques will be tight and strained, and that so what we can assume here, we are assuming, we are still assuming because we haven't asked, we will not directly ask her question, but what we can assume that there's a high chances that her perineum will be descending. So yeah, so there can be back pain issue present, yes or no? Yes. Okay, back pain can be present. Okay, and why the back pain is there? Is the due to the back pain factor or due to this weak pelvic floor factor? It can be the flat foot, it can be the weak pelvic floor. So they are all interconnected. Okay, so that is the central part, but you can understand how the downward assessment can give you simple understanding that affect over the pelvic floor. Okay, don't believe me. There are so many articles. You can just Google search, ask Chat GPT nowadays, AI, and that will also, you will get your answers, and they will send you, they will also, you can ask them about the research papers to evidence base and things and like this and that. Okay, so this is what I believe we are missing in our assessment. We are only rigid to one area. If patient is coming for knee pain, we are only giving her the care or rehab for knee pain. You don't understand this knee pain can be due to the weak or tight pelvic floor or weak or tight foot muscle. So this upper and lower, if they are weak, they might be giving this pain around the knee. That can be one additional factor, and this is what we are missing, this assessment. And if we are missing this assessment, we are missing complete treatment. Your patient will keep coming, keep complaining about the knee pain. Their knee pain will never go. So this is what I always believe, the whole body approach. If your patient comes for back pain, don't only focus on back pain. 60% your focus, your assessment should be related to the back pain. 40% your assessment should be of whole body, up to down. Anything, whatever your patient is suffering from. Knee pain, 60% assessment of knee pain, 40% of whole body. You might found different root, why, the reason of this pain. Okay, they are compensating. Okay, their body try to compensate all the time. So there might be compensatory pain, she's telling you. So go for the whole body assessment. I in my pelvic floor, I use this term, external body assessment. I can't treat the pelvic floor if my pelvic floor is tight and I'm keep doing that rehabilitation for 20 session, 30 session, and I'm not relaxing her jaw. So it will be always tight. So I have to relax the jaw also. I have to relax the feet also if there's a high feet arch. So it is a whole body approach, even to the pelvic floor. It is a whole body approach in back pain. It's a whole body approach in diastasis recti. It is a whole body approach in knee pain, high arch, everywhere. Okay, so this is what we are missing, and I really want all of you to go through that. What I'll do today, I will send you one form, assessment form, which I'm using for my pelvic floor patients. And in that assessment form, very important segment is an external assessment for the pelvic floor. That external assessment means whole body approach. So this whole body approach doesn't only apply on pelvic floor patient. This whole body approach is important for all the cases. Okay, go through that, and if you found value into that, you can ask, you can check those things on your other cases as well. That might help you. Okay. Is it making sense, all of you? Do you think it is making sense?
Yes, doctor.
Yes, ma'am.
It is making it.
Of course, it is.
So
Everything is interlinked.
interlinked. This is the whole kind of holistic link we need to say.
Yeah, I have a patient with this pelvic floor issue. So what you said, no, the same, she is having a genuine valgum and this foot is very flat. So I'm just seeing, okay, this is
Tomorrow you will
already
be
a
really excited to see her again,
Yeah, I'm just seeing because I just randomly she came for a knee issue. Actually, randomly, I asked this, how about your pelvic floor and all? She was telling me this and all. Then I thought, okay, I'll start the pelvic floor exercises also. So she was telling me, yeah, uh, she was having this urinary incontinence. This I asked very randomly. So she said she's having it.
So look, it is there. You have already.
Yeah. So
Thank you.
now I can link it.
Thank you for adding. So now everyone else will get discouraged. So only one question you can just ask them. Do you have a leakage issue? Can you control your urine? You can ask them in a very nicely subtle way, which is not offensive. Slowly after 1 or 2 days. So and try to find out. Okay. Lovely. Thank you. Thank you so much, Dr. Garishma, for adding this. It is very valuable. Okay, so shall we move? So far, what I told you, I have given you overview of, it is not only the pelvic floor, it is the whole body. And into whole body, you are missing pelvic floor. So this pelvic floor, let me explore, let me just give you a little bit of understanding of this muscle. If I'll ask any one of you, How many muscles are present in pelvic floor? What is your answer? The number of muscles? Can you please write it down on the chat box?
Too long. 16 pairs.
Uh-oh, who is this? Yeah, 16 pairs, Dr. Kharija. So there's a 16 pair. Isn't it kind of something excited and new? 16 pair. It means 32 pelvic floor muscle. In this simple area, 32 muscles are present. And when we say pair, so 16, because our body is in right and left. There's no muscle which is one. It is always right and left, right, left. So same way, pelvic floor is also, pelvic bone is also right and left. Ilium, pubic, ischium, so right, left. So muscles are also right pelvic floor, left pelvic floor. And they are joining around that, somewhere in between. And they are merging the fibers of right is merging with the left into the center of the pelvic floor. And through this center, the center of gravity is passing. Okay, so this is how these muscles are interlinked and they are present. So this is not only one muscle, they are network of muscles, so many muscles arranged in say different ways in that whole downward floor. And they are not only arranged right and left, they are arranged in levels. So as we have floor in our house, like ground floor and then first floor and the second floor, these muscles are also lying into the floor. So outside, externally, we have ground floor, then we will have a first and second floor. So we use the term more superficial, so superficial layer, more deeper, so deeper layer, and in between the superficial and deeper, middle layer. So this is superficial, this is deep, and there's another something in that, so middle. So the muscles are arranged into 3 layers: superficial layer, middle layer, and deeper layer. And the deeper layer means this layer inside this cavity. Now organs are resting onto the deeper layer. Okay, now canals are passing through medial and the superficial layer, and they are coming outside. If you are a male, so you can understand your penis, your penile structure is passing through the medial and the superficial layer. So that is not resting on to the deeper layer. But who is resting on the deeper layer? Bladder is resting on the deeper layer. Upper part of the vagina is somewhere in relation to that deeper layer. Rectum is on the deeper layer. But what is passing? Vaginal canal, lower part of the vaginal canal is passing. So lower part, not the whole vagina is passing. No? Lower part is only passing. Vagina is still inside. So lower part is passing of the vagina. Anus, anal canal is passing through the pelvic floor muscle. So yes, they are passing through the middle and the superficial, and their organs are resting on the deeper layer. So that's why the deeper layer, we are called, what the deeper layer has to do. If this is the organ and the organ is resting on me, so what I have to do, this layer inside, it has to always apply some tone, resting tone. So that should have a good tone. So the organ can rest in the same position without deviating the organ anteriorly or posteriorly, or effect of the any pressure or arm movement. Organ should not fall anterior posterior like this. So they should be supported by the tone of this muscle. So means what we want elevation of the organs, so organs can stay there. So elevation up, this is what we are calling another, some might be you have heard the word levator ani. So levator ani, so this deeper muscle, we are calling them as a levator ani, the muscle over which the organs are resting. So now levator, so what is the function of this levator, deeper muscle? Maintaining the support, higher tone. So not higher tone, good tone. So this good tone, so they can maintain the support and organs will not display here and there. Okay, so that is very important. That's why the name comes here, levator ani muscle. Okay, deeper layer. And we are also calling it the endopelvic fascia, the fascia which is covering the levator ani. So this is my skin and this is my cloth. So now how this cloth is on top of my skin. So this is the fascia over the levator ani. So this is we are calling it as an endopelvic fascia. Okay, so this fascia is a kind of one sheet, the facial structure, if you understand. So that is also very important. Any damage to this fascia can affect the whole levator ani. So you can say that during that penetration, during that childbirth, any injury to the internal fascia, levator ani muscles, overstretching when the baby is coming outside, any damage during that vacuum extraction, any damage during that internal, internal might be speculum, when they are inserting the scapulum, they are doing that assessment inside, they might do some damage. Or whenever they are doing some kind of radiotherapy, in case of cervical cancer, you can understand. So that can definitely affect the internal endopelvic fascia. So any deeper treatment done by the colorectal surgeon around the colon, around the rectum, even removing of the hemorrhoid, around doing this colorectal surgeries. It can be any gynecological conditions. They might do something, endometriosis is there, they have done surgery for that. They remove the uterus, they have done surgery for that. Any surgery through the vagina, even the radiation through the vagina, can they affect this endopelvic fascia? The answer is yes. So in this case, endopelvic facial sheath can have a tension, and that can give tension around this levator ani muscle, and levator ani muscle can become ascending pressure. It will fail to relax, and that can give tension. And in this way, the muscles will, if this part is tight, you can understand the whole muscle is going to somewhere stretch from some sides. So definitely one facial damage, one part of this facial damage can affect so anywhere. Okay, so it is very important. This endopelvic fascia should be relaxed completely. We don't want any tension with this endopelvic fascia, but there are so many of factors which can create a tension into this endopelvic fascia. Now, which tension? If I tell you that every month we are ovulating, you will be surprised that simply ovulation is also creating tension in our endopelvic fascia. How? You will understand that we have two ovaries, and out of these two ovary, one ovary is going to ovulate. So it means, like, out of these two, if I have my, okay, let me show you through this one. Yes, this one. This is another. So this is one ovary here, this one. So every month, one ovary is going to ovulate, either right or left. We have two ovaries present, right or left. If this ovary is going to ovulate, it means that particular side of the ovary is going to go for enlargement, because the eggs are getting bigger into that ovary. This enlargement of the ovary requires a kind of space. And this is somewhere directly related to our, because this organ is touching that our pelvic floor muscles. So when this dilation is going on, or the size is increasing even during ovulation time period, so 3 into we have a size 3 into 3 into 3 of the ovary, so that is going to increase. So that can create a tension in one side of our pelvic region, pelvic cavity. I'm not saying on the pelvic floor, one side of the pelvic cavity will be more restricted because the ovary is taking that space. So that surrounding area, the fascia, the peritoneal sheaths, they will go for expansion. The loading will be there. And due to this load, one side of the facial load will be high. And this can give you one side of that pelvic floor muscles under kind of load or tension, or their endopelvic fascia can be somewhere affected, or the muscles might be affected, congestion over that, or even obturator internus of one side. So we have this obturator internus. Now directly what is going to affect this ovulation is going to affect this obturator internus muscle, because this is organ is now lying like this. Look, if I'm putting this organ here, so directly this is going to come in that relationship around the area obturator internus. If obturator internus will be kind of uh, somewhere limited into action, because this muscle will not let, it will create a straining on that. So that can create strain on this muscle, and now these muscles are pelvic floor, which is coming from the fascia of obturator internus. If obturator internal fascia is restricted, that can give referred pain to these muscles also. So every female, they might feel, some of the female, they might feel that one side of whatever, like, every month, somewhere they might feel some kind of congestion on one side, or other month they might feel congestion on the other side. So you can understand even muscles are under the impact of that organ functioning, under this organ functioning. Ovulation can simply affect it. And so ovulation, second, if I'll say that uterus, so some females, they can have like, for example, okay, not only uterus, let's just stick to the ovary only. Assume that female who have PCOD, polycystic ovarian disease or syndrome. So what happens to their ovary? Their ovary will be more enlarged normally all the time. So because they are not, might be they are missing their periods, they are not having their egg release, ovulation is not going on. So the ovary size will be always big as compared to the normal female. So this big size can definitely going to affect that side of the obturator internus fascia, that side of the pelvic floor muscles, and that side of adductor, and that side of the body. I'm not saying the only pelvic floor, even that side of your obliques, what we say is the transverse abdominis muscle of that side. Every muscle which is around that area, due to this extra size of that ovary, that might be under the tension. Not only the muscle, their fascia, not only the fascia, even their lymphatic system, their arteries, their veins, everything will be under the load. Today only, I got one patient. She just she just called me, and she's going to come tomorrow for assessment. I'll discuss tomorrow with all of you. She told me that I have lot of kind of swelling all the time on one side of my adductor. One side of my vulva is always swollen. So now, the moment she said one side of the vulva always swollen, I asked her, like, what is your period history? Then she told me she's suffering from PCOD. So I'm just assuming she's going to send the reports tomorrow, and I'm going to see her tomorrow. But I'm assuming that there might be bigger size, and that might be affecting the whole system of the internus, the ductal movement, even that pelvic floor, and that might be that even she's saying that she has this what the vein issues also going on. Let me see tomorrow when she will come, and then definitely I will discuss the case with you. So yes, the PCOD is also going to affect your one side, whatever side ovary is swollen. Because the ovary, if I am ovary in this room, and I'm kind of oversized, so definitely I'm going to create some compression on others associated structure, whatever is there, anterior, posterior, fascia, nerves, lymphatic system, whatever is there. Okay. And what I told you when we started the session, mobility. So mobility around that area, that structure is going to hampered due to this ovary functioning. So that can be the reason of a lot of restrictions into the body. So now, what is the treatment? The treatment is increasing that movement, internal movement, and externally keep doing that stretching exercise, keep increasing the flexibility, keep lengthening the system, keep increasing the relaxation, so that internal, keep using a lot of breathing and expansion inside the body, pelvic cavity, abdominal cavity. Expansion is very, very important. Not only external stretching exercises, even internally, the expansion of the system, expansion of the abdominal cavity, so that internal relaxation can be achieved. So breathing is very important. That flexibility exercises are also very important. Mobility, improve any hot modalities which you can apply to improve the mobility is also very important. So that is again a part of the treatment. And the organ functioning. The moment you will improve, you reduce the restrictions, automatically the organ will start doing that organ will be free, and freely when they will move, the arteries which is supplying the organs, if they will move freely, the blood circulation to that area will be increased, and that is automatically going to improve the functionality of that particular organ. That organ can be ovary, that organ can be uterus, that organ can be fallopian tube. You might have, I don't know how much of idea you are having. There's another issue which is affecting the mobility of your reproductive system. The movement is mobility of your fallopian tubes. That mobility of fallopian tube is very, very important to move the fimbria of the fallopian tube towards that ovaries during the ovulation, so they can pick that egg. So this mobility of the fimbria, the mobility of the fallopian tube, so that they can pick that egg after ovulation, and they can transport the egg towards the right part, ampulla, where the egg has to stay and wait for fertilization. So mobility is very important. So you can understand if somebody is having assume the scoliosis, any female who has this kind of scoliosis, and that is a kind of chronic, and this you can understand that that side of ovary, that side of ovulation, that side of the fallopian tube, that side of the functioning of the reproductive organ will not be good in her case. So automatically this movement is going to affect not only the spine, the muscles, even internal organ health. So it is not only one approach which we are taking, musculoskeletal, internal organ mobility is equally important for the better functioning of a person. So we definitely, our focus is improving the function of the body by taking care of the internal organ mobility also. So that should be always our first priority. Okay, so you can understand that PCOD and blocked fallopian tube. So what is a blocked fallopian tube? Your ovaries, your fallopian tubes are blocked. Either the sperms are not able to travel, either that eggs are not going to travel. Somewhere, something is hampering that fallopian tube. It can be the tension, it can be adhesion, it can be the restriction of the movement around that area. So more mobility will enhance the chances that better functioning of your every organ of that side, whatever side is impaired or impacted due to this congestion, due to this kind of swelling which is going on over the ovary or over that area. So very, very important. So yes, ovary on ovary functioning, ovulation, PCOD can have effect on the endopelvic fascia and one side of the restriction. And that can give you the congestion. Again, we can use the term pelvic congestion, which is a kind of broad term, like constipation is again a broad term. Pelvic congestion of right side, or pelvic congestion of anterior, pelvic congestion posterior, pelvic congestion around middle area. So in middle area, it can be the congestion due to endometriosis. If any female who has uterus related issues, like she has a hyperplasia into uterus, bigger size of uterus, or swelling of the uterus in case of PCOD, too much of bigger size of uterus is there, or fibroid is there, that is increasing that uterus size. So you can understand the middle, somewhere middle load is there, and the load can put definitely load into the central area, which is the central part of your body. So central part means the central part of your pelvic floor also. So the load can affect your pelvic floor central part. It can give you weakness, and endometriosis can give you tension. And anything, cervical cancer, when you are treating that central part through the vagina, that can create the radiations can create a stenosis of the structure, vaginal structure. Vagina can go for shortening, stenosis. So yeah, so in this case, if vagina is going for stenosis, the endopelvic fascia can go for stenosis. So this post-cervical cancer rehab, pelvic floor is must. And now that is the second most severe cancer which is spreading very commonly across the world. Even in India, so many of female, they are diagnosed with the cervical cancer in stage 1, 2. If we are very active, so either might be stage 3. So they have to go for chemotherapy. So many of like their hormones are getting affected, their structures are getting affected, chemotherapy, radiations, this kind of when they are doing the surgical removal of those organs. So it is affecting their pelvic or area, pelvic floor, endopelvic fascia, creating the tension and tightness and restriction and mobility issues. So you can understand what is the treatment in those cases? Improving the relaxation and mobility, whatever way, externally or internally, whatever approach your patient is allowing you. So it is highly important around that uterus. Same way, when patient has a piles going on, and he or she, piles is not only happening in female, that can happen in male also, because of this constipation, defecation pressure all the time. So they're like, always putting downward pressure, that kind of sound, loading, over the pelvic floor during the defecation. So that can always create a lot of tension around that area. And even when the patient is going for any anorectal surgeries, any you can understand this hemorrhoidectomy. So they can definitely create effect over that muscles around that area, which is around that anus. So stenosis can happen, weakness can happen, the tissues can get damaged, so they might get tension. So we need to again improve the mobility, improve that blood circulation, so better healing can happen. Then working on to the mobility, and then working on the strength. So one after another, when there are one stage, two stage, or three stage treatment, we have to understand what has happened with the patient. If patient has she has gone through the like, you can understand that hemorrhoidectomy, hemorrhoid has removed, so the first stage tension will be there, and so first stage the healing is going on. So first is improving the blood circulation. After improving the healing, second, the tension will be there, reducing the tension. After reducing the tension, the third stage will come, where we will start activating the muscle, activation stage. And on the fourth stage will come when we start working on to the strengthening. So step by step procedure: healing, and then relaxing, then activating, and then strengthening. So 1, 2, 3, 4 stages. So depending upon what happened to your person, that is very, very important. Rehab is depending upon that situation. Okay, and that's how the patient is going to take 1 session, 10 session, 15 session, 2 month. That is also always depending upon that particular phase. If someone has removed, she was suffering from prolapse and she has removed her uterus. So when she removed the uterus, so in initial 1 or 2 or 3 months, healing is going on. So in that case, we will focus as a physio or as a pelvic rehab therapist on healing or improving the blood circulation into that area, so better healing can take place. So healing, and after that we'll start relaxing whatever effect happened, because when they will remove the uterus, what will happen with the vagina? So they have to suture the vagina with the pelvic cavity, and then the tension will be there around the vagina. So first, let the healing happen. Second, let the relaxation happen. Let create the relaxation and increase the mobility, and then we will activate the muscles, and then we will put the female on a strengthening protocol. So this female can take more time. So depending upon that, it is very important to understand this pelvic organ and their relationship with the endopelvic fascia, and that their relationship with the muscles. It can be the obturator muscle, or it can be that pelvic floor muscle. I hope we are clear about the organ relationship with and their functioning relationship with the pelvic floor and their effect. Are we clear?
Yes, doctor.
Keep writing. Any doubt, ask me at the end of the session. Okay, so finally, I hope you understood the whole body up, down. And another thing which I missed is, that this is what, one important segment, ISA. Who can give me the full form of ISA? In our body, which we are missing, all of us, we are missing in our assessment. ISA stands for what? Infrasternal angle. Okay, so what is infrasternal angle? So this is my sternum, this is my ribs, right and left. They're going downward, and can you see the right and left? They're creating one angle here. All of you palpate your ribs and join your hands such a way that your upper finger touch the xiphoid process. Right and left. Can you feel what angle is they are creating here? Yes? They are making one angle?
Yes, ma'am.
So are you checking this angle, and what is the importance of this angle? Have you ever checked this angle in any of the patient? Yes or no? Or any understanding about that angle assessment? Hopefully no. Most of you. Yes or no? No. Yeah. So it is very important, very important, very important. Now how? Why? All right. So we call it as an infrasternal angle, and I think it is going to take. Okay. What I'm going to give you another homework. Infrasternal angle. You, if you have time, that is a third homework. Look for that, an infrasternal angle relationship with your back muscle, with your abdominal muscle, your diaphragm, and your pelvic floor, if you have time. Otherwise, I will explain you in detail in our upcoming session during the assessment, because it is very important part of assessment. And this angle, okay, if I want to tell you in a short, very short story, long story cut in short. So what happens actually, every male or female, normally, we have a one significant angle present. So the male can have a narrower angle as compared to female, because our body in such a way, we have an external organ, extra organ in our body, and that is uterus. So due to that, we have a kind of more wider cavity. Pelvic inlet is more, our pelvic cavity is wider. So same, like we have more expansion into pelvic cavity, and that is going to give expansion to the abdominal cavity, lateral expansion, and that is going to give a little expansion over the this thoracic cavity. So, and we have breast also over here. So they have a different structure. So our infrasternal angle is a little bit wider as compared to male. So if this angle is wider, it means who is away from each other in female as compared to male? The ribs. So ribs are more kind of away from each other as compared to male. Okay. So due to that pressure of your breast and your downward structures. So now normally this angle is approximately 70° in male, and this angle is approximately 80 to 90° in female. Now another thing is when and how you are checking this angle. If you are checking this angle in lying position, if the female is in supine or male is in supine, the angle can be 90. If you are assessing this angle is in a standing position, it can be a little bit here and there. So 80 to 90 in female, that's a normal angle, and 70 to 80 in male. So all of you check your angle. You can use the goniometer. You can just mark with the pen by just palpating the ribs of one side and mark down to up, last rib to up, and try to just see that how much angle it is creating. So normally in normal female, it should be 90°. And during that, male it can be 80 max. So now how it is important? So if this angle is more than 90 in a female, so what does it mean? It means that ribs are away from each other. Okay. If the ribs are away from each other, so let me just assume that this is not pelvic floor. Assume that this is the thoracic cavity. Assume it is a thoracic cavity. So I'm talking about this angle. Okay. Assume that this angle. This is a xiphoid and this is your ribs. Okay. So this should be 90°. If this is more than 90, so now what happened? The ribs are away from each other. If the ribs are away from each other, the angle will be more. So what will happen to the thoracic cavity? In this case, and we in thoracic cavity, we have a diameter, anterior posterior diameter. We have lateral diameter also. So if the ribs are, this angle is wider, so which diameter of thoracic cavity will increase? Lateral. Yeah. Lateral diameter, am I right? Yes.
Yes, ma'am. Yes.
And what will happen to the diaphragm? The muscle which was like dome shape. If these ribs are going away, so what will happen to this diaphragm? It will be descending or ascending? Descending. Yeah.
Descending, it will flatten.
It will flatten. If it will be descending, so one function of that diaphragm will be always restricted, which contraction. Diaphragm will fail to contract. Dome will not happen. It will be descending down. So now due to this descending down, the air, whenever air is coming in, air, and when we are exhaling, so during exhale, it should go like this, diaphragm. But this functioning during exhaling will not present. So now diaphragm function will not be proper. So patient will be only keep doing this kind of thoracic breathing. So because the air will not be able to push the diaphragm upward during exhale. Okay, so it will be always shallow breathing. Patient will keep doing, and there will be always, there are high chances that the flattened diaphragm and flattened abdominal diaphragm. What does it mean with the abdominal cavity? If this diaphragm is flattened, so now which muscle is coming from the center of the xiphoid, right and left? Rectus abdominis, right and left. They're going like this string, and they are inserting into the pubic symphysis, complete string. So now, if these ribs are away from each other, so what will happen to the rectus abdominis muscle? Think about that tomorrow. And when it will be kind of away, descending pressure, rectus abdominis muscle is going to affect. What will happen to the obliques, internal and external obliques? What will happen to back? So understand that. And this is very, very, very important part. And now coming to this is like kind of core. When I tell you that, so this is descending, diaphragm is descending, so it means which pressure is increased, where pressure is increased, abdominal pressure is increased all the time due to this downward descent. So abdominal pressure is increased, so means from inside, the balloon will be always an inflated balloon that is going to give more strain over the abdominal muscles. So is there chances of diastasis recti in this case?
Yes.
Okay. And if diastasis recti will happen, the diastasis recti will happen, it will fail to pull ilium in a neutral position. Okay. It might be like this. It can be like this. It will fail to pull it in a right position. So very, very important. And this ascending pressure will be, abdominal pressure will be kind of high. And this abdominal pressure is going to always put pressure over pelvic organs. So due to that, pelvic organ will be always compressed and descend down. And when the organs will descend down, their legs, means their passage, will also be under the downward pressure. So now when they are under the pressure, their muscles, pelvic floor muscles, which is holding the legs, will be also under the pressure. So what can happen to the pelvic floor in these cases?
It can cause weakness.
Weakness. You can understand. So it can be weakness into pelvic floor. So very important, assessing this infrasternal angle. It can give you downward displacement, displaced pressure, downward displacement of abdominal diaphragm, downward displacement pressure of the abdominal, pelvic organ, and weakness of the pelvic floor. And when the pelvic floor muscles will start getting weaker, it will fail to pull the ischial tuberosity closer, and it will fail. It is going to give you the genu varum, and it can give you the flat feet also. So it is very, very, very important assessing infrasternal angle. So your homework is tomorrow, all your patients, when they are coming to you, you just assess their infrasternal angle and try to correlate with their issue. Is it that something which you are not assessing and might be somewhere important? The moment you will correct this, we call it as a rib flare. Okay, rib flare, this is a term which we use. Ribs are flared. So now what is the treatment? You reduce this pressure. So reducing the pressure by relaxing those muscles which is tight and strengthening, activating those muscles which is weak. So that will be strengthening, relaxing and strengthening both program you have to give your patient, which is creating this kind of rib flare or increased infrasternal angle. And this angle is always very high during pregnancy. when your baby is getting, your uterus is flared up and that is putting pressure over your ribs. So they're high, there's always high, 100, 110. We'll always assess your patient during the pregnancy, it will be always high. So we have to keep correcting that infrasternal angle, keep relaxing those muscles which is tight and pulling the ribs outward. So relax those muscles and strengthen those weaker muscles and automatically try to relieve the back or abdominal strain or the pelvic strain. It is very, or that strain which is going on downwards. And this infrasternal angle is going to affect your shoulder movement also, your trapezius pain also. There will be upper cross syndrome present, the tightness in your body. So there are so many things which is related to the infrasternal angle. And yeah, because we are not discussing a lot of about the core, we are discussing about one part of the core, which is pelvic floor, but I'm giving you that important understanding that this is all interconnected. So understand about infrasternal angle more into detail and how it is going to affect your upper body, lower body, pelvic floor, abdominal, back, and thoracic, lumbar, every region of your side, and we are missing it. No one has ever taught us this assessment, and that's why our patients are not always 100% corrected whenever or treated, or they are getting relief, because we are missing so many things. We are missing infrasternal angle, we are missing pelvic floor. Somewhere we are. That's why this whole core is not core means abdomen. No, core is not only abdomen. So if I'm saying that. I done. If I'm saying that this is the core, anterior, side, back, down, and up. It's not only abdomen. So keep always treat your patient. It can be male or female, even male. Obesity. So whenever there's a kind of big tummy, visceral fat is high, big tummy. So what can be present in those obesity cases? What kind of angle? Wide or narrow? Wide. Okay, there are high chances any obese person, can be male or female, that angle can be wide, and we have to correct that angle. Very, very, very important. That was the second thing. So I haven't given you any understanding about that reality. That was the overview which we discussed in today's session. So now I hope you understood that central, pelvic floor, downward bit idea, upper bit idea, and never treat it only pelvic floor, only back end like this. Any question you can ask me. Muscles, step by step, all these 16 pair, we will understand in more detail, layered wise, superficial layer, middle layer, and deeper layer. Okay, now tomorrow we will start that. Now if I'll say that you have a female in front of you or male in front of you, and now forget about the externally. Assume that your patient is telling you, okay, we are going to go for assessment, and your patient, the first guideline, we are telling the patient, okay, remove your clothes and lie down, because we want to see that pelvic floor. So I'm not going the whole body approach. I'm just want to assess the pelvic floor. So for assessing the pelvic floor, the clothes should be removed down there. Okay. So lower half, we'll tell them to remove the clothes, even including the panties, if it's a male or female, both. Once they will remove that, depending upon what we will see externally. The first thing is hair, presence of hair. And we know that if she is a female, so there will be vulva, mons pubis and vulva. If he's a male, there will be mons pubis and penis, you will see, as soon as they will remove the clothes. So this is a male and female. But once they are on the table, so the first thing which can be seen is their genitals. The second things which is going to be observed by us will be hair. So pubic hair, the presence of that, if it is not shaved. Some people they shave, some people don't shave. It doesn't matter for us. So we call it as a pubic hair. So we know that hair is present around that area. Pubic hair, that hair are all also present around that vulva, So labia majora, so hair is present. And assume that assume that you are removing the hair. After removing the hair, the skin will be visible. Okay, so assume that you are removing the skin also. So once you will remove the skin, now internally subcutaneous tissue will be present. So after that, uh, muscle will present. Which muscle? Superficial layer of the pelvic floor. So superficial muscle will not be visible. You have to assume that under the skin, subcutaneous tissue fat layer is there, and under that, muscle is present. Okay. Once you assume that we are removing the superficial muscle, after that, in a female body, very important organ will be there. We call it as a clitoris. So let me show you. So she is a female and we have this external skin. There's no hair. So external skin, underneath the skin, this will be present. What is this? Pelvic floor muscle. Superficial layer, muscles around there, like some muscles present here, some muscles are present here, some muscles are present here, some muscles are present downward, superficially. And once you remove this muscle, so look, these are the muscles superficially. And once you remove this muscle superficially, there will be another structure present here. And what is this? This is female sexual organ. Now I'm making a very, very important statement here. Vagina is not sexual organ. Okay, vagina is not a sexual organ for female. Vagina is our part of reproductive system. There is no sensual nerve present inside the vagina which is giving us sexual feeling or stimulations, or female cannot have orgasm only with the vaginal touch or vaginal stimulation. Okay, so vagina is not our sexual organ. Female sexual organ is clitoris, and clitoris is not only this pinch kind of P-shaped small structure which is present here. No, it is deeper than that, like ice tip of the iceberg, which you can see externally is a tip of iceberg, this clitoris, and this clitoris is big like that, quite big. It is the same size of a male penis, but that organ is hidden inside. Male penis is externally visible, but our organ is quite big. This is the legs of that clitoris. This is the body of the clitoris, and this is the glands of the clitoris. What is visible externally is only this glands of the clitoris, which is kind of small P shape, and everyone is saying the clitoris is a P shaped small organ. And people are saying that vagina is a sexual organ. The answer is no. Vagina don't have any sexual nerve. If vagina would have been that sexually stimulated, so try to understand during the gynecological examination, whenever any gynecologist she's touching vagina, so females should have this kind of sexual sensation, but no one of us, we never had this sexual sensation whenever any doctor is touching us. Why? Because there's no stimulation, there's no nerves into that which is going to give us that sensation. If you will directly touch our clitoris, we will get sexual sensation. Okay, because this organ, you are touching that organ which is responsible for that functioning, clitoris. So this clitoris is present just below this superficial layer of the pelvic floor. Bulbocavernosus, and another muscle is present here, ischiocavernosus. Once you remove these muscles from one side, you can see this organ is present, clitoris. Okay, so that is very important. So that was a superficial muscle, and this is the part which is visible externally, but organ is completely inside, hidden. Our problems are always hidden. We are hidden. We try to hide our problems. We don't speak and we are shy and this and that. God has given us this hidden organ also. And you will be surprised. I should not give you so much homework. So I will send you one video about the clitoris, the truth about clitoris. The world, the whole world, even the science was not aware about this big organ present in our body since late 90s. So whole era so far, people were not knowing that we have another organ in our body, and that is clitoris. So I'll send you that video. There are so many videos like that you will find. So still myths are there that vagina is a sexual organ. We have to have intercourse without inside the vagina. And male, most of the male, they don't even know about this important fact. That's why they fail to, when we say the satisfactory rate between male and female, 80% of female, they are not sexually satisfied because their partner, they are not aware about that important fact of their life, their women's life. Even as a woman, we don't know about the important factor of our life. So about this clitoris. So I'll send you one, whenever our session will be off in between during the festival time period, I'll keep sending you some videos. So I'll send you the video about female sexual health. That video is around 4 to 5 hours, and that is going to give you more clarity about the female sexual functioning and what is important during the sexual stimulation for a female, and how we have to understand our body and how we have to convey this to our male so they can also understand what we like and what we don't like. Okay, so that's very, very important. That's why 80% of female, when they are not sexually like kind of satisfaction is not there. So that reason is we are not aware about our body fully. So this is the organ present just below the superficial layer. And once you remove this organ, then the another layer will come, middle layer of the pelvic floor. So this is the middle layer. This is the clitoris, and this is the superficial layer. So can you see the clitoris is sandwiched between that pelvic floor muscle. So the more good muscle, now we need sexual sensation, means orgasm is a word, very good word. So when we say orgasm, so for an orgasm, we need this muscle, this organ to get stimulated. So who is going to give stimulation to this organ? The first is the more erection into this organ. Like male is having erection which is visible, but female also has erection which is not visible, which is inside. So during this, when the blood comes into the penis, it goes for kind of erection. Same way, when female is aroused, blood starts coming into that organ, and it goes for kind of erection. So erection happens in the whole legs of that. So whatever size of this legs, it is going to go for more dilation. So more erection is directly depending upon the blood circulation, how much blood capillaries, how much your heart is functional, your arteries are functional. So that is going to send a lot of blood into that area. And there's more signs, nitrous oxide release is there, what the female is thinking, she really want that hormones to come into action, which is going to give direction to the heart to pump blood towards that. So it's a kind of quite deep science which will be explained to you. I will share the video today only. If you have time, you can just go through that. If you don't have time, whenever you have time, you just go through that video. So it's very, very important. So erection. Now you can understand erection means swelling of this organ, inflation of this organ everywhere. And during that inflation, what will happen to it is going to push that pelvic floor muscle anteriorly, posteriorly. And during this activity, if female pelvic, so what sort of pelvic floor muscles we need? We want the muscles which can relax when this is going to go for expansion. So muscle should go for relaxation when the erection is going on here. And once the erection will be achieved, what we want? We really want at that stage also to keep going for relaxation, or we want contraction? We want toned muscle. The more toned muscle female will have, the better it will compress the nerves. The whole organ is sending signal to the brain. So the more good tone into these muscles, superficial and middle, or pelvic floor, they will keep compressing this organ. More compression of this organ means more stimulation sending to the brain, and female will have more better sexual functioning going on, and that can lead to orgasm. So means which sort of pelvic floor muscles we need here? The muscles which can relax to facilitate this erection, and muscles which can contract, which has a good tone. So any female who has a weak pelvic floor, weak muscles they will fail to create a compression over this organ during the stimulation phase. We have a certain phase of sexual functioning. like desire phase, arousal phase, stimulation phase, and then we have orgasmic phase. So you can understand when you don't have a stimulation, you will not have orgasm. When you will not have orgasm, you cannot have relaxation of your body or your mind. That type of female will never get orgasm. She will never get sexually satisfaction, or she will also be always frustrated female because her brain and body never got released. So orgasm gives you your mind, it will take your mind into deep state of relaxation. So very, very, very important. So who is important for this functioning? Yeah, I know that psychologically relationship with the partner and I want to go for it or I don't want to go for it. It's my mind, my brain command. So that's the first factor. And after that, psychologically, physiologically, my body, how my body is responding, the hormones is important. Then the right hormones is important. Then right functioning of the heart is important. The functioning of the respiratory muscles are important. The functioning of your pelvic floor muscles are important. If the muscles are good, tone, better relaxed muscles, better toned muscle, better good orgasm female can have. And that is the completion of the sexual activity, means completion of that physiological need, means brain, mind, psychologically female will be more relaxed. So it is very, very important, which is affecting this simple organ. Not simple organ, it's a unique organ. God has given us something extra. And we hope that thankfully in our generation we are aware about that, but our mothers, they were not aware about this important fact. And we really want you and even gynecologists, they all are aware about this fact. So, but they are not telling us. I don't know why, what is the reason, but I really want, we are not loud, we are not going to the society and telling them, oh, this is your clitoris. No, at least whoever is telling you in your life that they are having some issues related to their sexual life, so we can give them answer. But when we can give them answer, when we have clarity. So having this clarity is very, very, very important. So so you can understand the superficial muscle, clitoris, middle muscle, and after that this deeper muscle, levator ani. And through that, we have three openings: urethra will cross, vagina will cross, and anus will cross. So this is how these muscles are layered up in superficial, middle, and deeper. Between superficial and middle, clitoris is present in a female body. In male, between superficial and middle, prostate is present. That is attached. Middle layer is attached with the prostate, not the superficial. Middle is attached with the prostate, which is a male organ. So same way, externally, superficial muscles are attached with, if I just show you, I'll show you tomorrow. I have I will show you tomorrow. Penile structure is also there. So you can see that how that muscles of pelvic floor are attached with the penis, base of the penis. If this is the penis, so half of the base of the penis is covered by the pelvic floor muscle. So very beautiful present, like kind of support to that sexual organ. Or penis is not only the sexual organ, it is doing the multiple. Yeah, penis is a sexual organ, but the urethra has a different three function. So that muscles are attached with the male sexual organ. And after that, superficial, middle, and the deeper is a levator ani, which is going to just come in with the relationship with the organs. So this is how beautiful body is there. Pelvic cavity, pelvic organ, supported by very nice, very good muscle, pelvic floor. But fortunately or unfortunately, this muscle, God has not created this muscle for taking that much of load off your abdomen all the time, because whenever we are standing, our abdominal load, upper body load is always falling on this muscle, pelvic floor, and the gravity is also pulling it down. God has not created us like this. He has given us a big muscle to work against the gravity, not this small muscle. God has given us which muscle? Abdominal, because we were on our four when our ancestors. But this revolution theory from four, like when we were on our four, like animals, the big abdominal muscles used to build for work against the gravity, against this abdominal load, and the load should not go to that back muscles, isn't it? That more muscles through which the passages are passing. But due to this revolution, load transfers, and the load came into over this small muscle, and that's why issues happens, pelvic floor issues. I think very beautifully God has designed us. And yes, as a girl, we are so lucky because God has given us urethra for urination, clitoris for sexual functioning. God has given us vagina for reproductive functioning. So 3 different organs for 3 different functioning. So reproductive functioning, period coming out, baby coming out, sperm going in, vagina is there. Urination, that urethra is there, and sexual functioning, clitoris is there. But for male, they have only one organ, penis, and into the penis there is one urethra, and that urethra is responsible for reproductive function. So means ejaculation is going on through the vagina, through the penis, ejaculation of the sperm. Urination is also going on through the same urethra, which is crossing from that penis. So penis is an organ, and through this is organ, and through that this urethra, when canal is coming, and through this canal ejaculation, urination is going on, and this organ, the whole external part around any space around then this surrounding this canal urethra, we are calling it as a corpus cavernosas of the male. The penis in our inside the penis, corpus cavernosas are present, but that penis is responsible for erection. But as a whole, if people don't understand urethra and penis as a different entity, so we can use the simple word penis. So penis is responsible for erection, urination, and ejaculation. So we are favorite to God. God has given us 3 different functions and one 3 different organs for 3 different functioning, and one organ to male for all these 3 functioning. So we are happy. We should be happy that we have 3 different organs. We can become mother. They have different strength and things, but we are blessed. So this was a kind of bit understanding about initial of the pelvic floor. I hope now I'm going to stop my session here. I hope you get a little bit out of today's session, and you might find it valuable. Anything which you found valuable, you must have written it and keep making notes, because as I told you that it's all experiences which is keep adding. Things are sometimes it is not even into the books which we keep discussing. So keep making your notes. You can always keep checking it through different platforms. One day you will get answer that it is right. One day you might get answer that something was wrong. So don't worry, let me know also. I will also learn with you. But hopefully I will not give you wrong information. Okay, take care of yourself. All the very best. I'm so happy that we have a girl and boys both into these sessions. And if you are a girl, keep shining, keep spreading this awareness with other women in your life. Support them, because no one is supporting them with these intimate health issues and private health issues, or bladder and bowel health issues, or sexual health issues, not even discussed. Same way, if you are a male, so I hope that you can understand better. You are female now, and you can also give these guidelines to your male friends, convey the right information to the world. We can generate the education, focus on to awareness. That is also part of physiotherapy. Okay, so take care of yourself, keep loving yourself, stay happy, and stay informed, and stay full of love, full of information, full of acceptance all the time, and love the person you see in the mirror every day as soon as you wake up. So keep looking in the mirror and keep smiling all the time. That's going to give you a different side of different kind of experience, positivity. This positivity is going to give, who is going to give you this positivity? You. So believe in yourself. This world is just revolving around you only. If you are not there, nothing is there. So love yourself. This is what I really want. Take care of yourself. See you tomorrow. Any question you can ask me.